So I'd like to chat with you about how I treat patients who have been newly diagnosed with metastatic kidney cancer. Clearly, this is a distressing diagnosis, and there are a number of treatment options that one needs to sort through. So I wanted to take you through that logical process of deciding which therapy is right for each individual patient. I typically begin this discussion with my patients by walking through the generations of therapy that we've seen for kidney cancer through the years. In the 1980s, chemotherapy, the same chemotherapy that might be applied to breast cancer and prostate cancer, was the mainstay of therapy. In the 1990s, this changed radically with the introduction of interleukin-2 or IL-2 and other immune-based therapies such as interferon. I'd like to refer you to my post on Cancer Grace related to interleukin-2 therapy to learn more about that treatment modality. What I'll really focus on today, though, is the advent of targeted therapies for kidney cancer. These are treatments that really hone in on the underlying and fundamental mechanisms of kidney cancer. One thing that we've come to appreciate is that kidney cancer is a very vascular or blood vessel-rich tumor. So many of these targeted therapies that we have for kidney cancer are really geared at making sure that we can reduce that blood vessel supply to the cancer. There are a total of 7 targeted agents that are approved right now for kidney cancer therapy, and these have 2 distinct therapeutic foci. One group of agents attacks a molecule called VEGF, another attacks a molecule called mTOR, or mTOR. In terms of deciding which of these 7 agents is right for the individual patient, I typically look to the setting in which the drugs were approved. One agent, for instance, Sutent, was approved in patients who have been exposed to no prior therapy for kidney cancer. And by virtue of that, because that study demonstrated a significant benefit in delaying the tumor and a borderline benefit in improving survival, I tend to favor use of that agent in the first-line setting. That's just one example of several potential therapeutic options. Guidelines such as those by the National Comprehensive Cancer Network suggest that pazopanib or Votrient or bevacizumab, which is also called Avastin, may also be appropriate choices in the first-line setting. I have to say that because of the familiarity of the toxicity profile and because of that borderline benefit in survival, I tend to favor use of Sutent in the first-line setting at this point in time. That being said, for every patient who comes through my clinic with a new diagnosis of kidney cancer, I always try to emphasize the potential for participation in clinical trials. We have a number of clinical trials that we hope will take the benefit that we've seen with agents such as Sutent, Votrient, and Avastin, and really take them to a new plateau by combining them with novel therapeutic directions such as programmed DEath1 or PD-1 inhibition. I think that through your participation in clinical trials, we may not only move the field forward, but we may actually perhaps lend benefit early on in your disease course.